all in favor of Joe heading up the IRC?
Yeah,
Aye.
the system needs you.
All right, welcome to the program, Jay. Good to see you, my friend. Another exciting adventure for us today.
Yeah, I'm really excited, Joe.
Always.
Glad to be here. How you doing, buddy?
Yeah. Good, man. Good. So we got Alexandra Perry as our guest today, and I know you have some previous experience with Alex, quite a bit of it. And tell us a little bit about Alex before we bring her on.
I couldn't do that in a short little bit, but I'll try. Like, the reality is you meet certain people along the way that are true change makers, right? True impactful change makers, and Alex is one of those people, right? You know. She's got a drive like none other. She's intelligent. She's articulate. She's excited. You know, she brings a wealth of experience, a wealth of knowledge. You know, we're really fortunate to have her here today. I've had the privilege of doing a different podcast with her on a different occasion, and over the past few years, I can say that we've become really, really good friends. You know, and so this is a little bit more than just a professional situation today. I really care and adore Alex. So yeah, I'm really excited. I'm really excited to have her here.
Right. There's a couple of subjects that we want to dive into. And so, well, here we are.
Lot, really.
So, yeah.
Well,
so there,
Joe, like, there's a lot.
Ahead,
like,
Jay.
you know, sorry, Joe.
No.
It's like one of the things I really wanted to talk to her about, because I'm really, so as you know, I teach addiction and mental health at Centennial College, and one of my classes that I'm a professor for is social policy, legislation, and system navigation, and the social policy. And so what I've done was recently is we unpacked this little sort of debate in my class about the new laws, the new policies that are being brought out and implemented in Western Canada regarding involuntary treatment. And it's an interesting debate. It's an interesting topic because, you know, it touches so closely on so many different things, you know, and there's some people that are very strongly for it, some people that are very strongly against it, and then many people like myself who can change their mind on it every day. You know, I really, you know, I struggle specifically with this whole, like, I had a guy come into me many years ago. He come into treatment and he comes up talking about another guy and he says, you know, this guy's here for the wrong reasons. And I said, well, what's the wrong reason to be in treatment? You know, like, I couldn't understand that. And I've heard those lines all my life. You know, it's not for people who need it. It's for people who want it. I don't know if I wanted recovery when I went into treatment. I just know I didn't want what was existing in my life, which was alcohol and drugs. Like, I don't know what I wanted, but I know what I didn't want. Right. And so, you know, this whole piece about involuntary treatment, I mean, in 1984, what Bruce Lee, he said, you know, when the student is ready, the teacher appears. So how do we know when that's going to be? Right. And really, but I guess the bigger questions is what's the scope? I mean, where's the definition? Like, where does the line draw in between us forcing someone to receive help? You know, and does that actually start to create a narrative of resistance and rigidity? Does it actually create a bigger problem? You know, or is this just to, you know, ease the masses, right? Let people think that that society and community is doing something bigger and broader. You know, is it just, or are we getting desperate? Like, I don't know, right? Where do we invoke internal motivation? Where do we, you know, how do we get somebody to want to do something? Like, I mean, these are big questions, right? And I'm not suggesting Alex or myself or you, Joe, or anyone else that's listening has those answers. I'm just suggesting that it's a discussion that needs to be had, so people can formulate more informed opinions and make more informed decisions it. But yeah, and without any further ado, let's do it.
So here we are. Alexandra Perry is the National Director of Substance Abuse Policy and Programs at SOMA, where she's helped design a more integrated, compassionate, and evidence-based approach to substance use, recovery, and return to work across Canada. Before stepping into national systems leadership, Alex played a key role in Toronto's COVID-19 response, while working with Homes First Society, helped build and oversee several of the city's hotel-based shelter programs, supporting frontline teams, managing complex client needs, shaping policies during one of the most challenging periods for the homelessness sector. She brings experience across addiction care, disability management, trauma-enforced practice, organizational leadership, She's also completing her PhD in industrial and organizational psychology, where she studies leadership, stress, and change. She's passionate about creating practical solutions that work for real people, workers, employers, clinicians, communities. And we'll explore the challenges and discuss emerging approaches, including her take on those new involuntary treatment programs in Western Canada. And so here we go. Alexandra Perry, welcome to the program. Great to have you here. Thank you for doing this.
Thank you so much. That introduction. I mean, from both of you, I'm just like so blushing. It's like I officially want you both to introduce me to everything in my life going forward. Oh my gosh, I have like tears in my eyes. Anyways, thank you so much for having me. And yeah, just really excited about today's conversation and ready to dive in with you guys.
Yeah. Right. We're going to follow you around wherever you go to introduce you here or there. So here we go. So, but the first question I have for you is Alex, what got you started in the recovery biz, if you will?
Yeah, it is a personal start for me. Part of my family, a lot of my family has struggled with substance use. My father, I lost a few family members recently over the years, and I've really seen the generational impact, unfortunately, when it comes to substance use and trauma. So yeah, it was an early calling. I think I remember when I was, finishing university, my dream was to become an interventionist. I loved the show Intervention. I would watch it religiously. And that was kind of my whole life. And actually a place that we have all, I think, in common gave me my first start as a part-time counselor. And from there, it just grew very unexpectedly in a beautiful way. But I really just wanted to help people and hopefully bring that family perspective, the family member perspective into the conversation a bit more too.
Jay, you want to, I was going to ask you again, like, you're there still with us, Jay? I wanted to,
I'm still here. Yeah.
Go ahead, Joe. We talked before Alex, you joined us, and you heard us off the air, but we wanted to, I guess, dive right into this business of involuntary treatment and what your take on it is, and where is this headed?
Yeah. So, just reflecting on this a little bit before the call, I was kind of getting my thoughts together. And I think there's kind of maybe 3 or 4 things that we would want to cover in today's conversation. So kind of the history of it, where is it coming from? What are we seeing now across Canada? Who's eligible? Like, what's the criteria for these types of interventions to take place? And then lastly, what are the risks? So I can maybe walk us through that if it would be helpful. As Jay said, it's a very complex and tense conversation right now, controversial, if you will. And it's because something like involuntary treatment comes from this really older, traditional, institutionalized approach when it comes to mental health. And this was back when, systems were really built with an intention to protect, but, it removed people's autonomy. It was very harmful, realizing, perhaps years after that, a lot of the approaches were quite unethical. And so, to hear this language again when we're in 2026 and we've had so much great progress when it comes to mental health and how we talk about substance use. It does feel like we're going backwards a little bit from that sense. Now, specifically for places like Alberta, the involuntary treatment is being shifted or framed as a compassionate intervention act. So every province is responsible, essentially, guys, for their own mental health and substance use processes, policies, funding, all of that kind of stuff. There isn't one overarching model that supports our country through how we respond to this. So like BC, Alberta, Ontario, everyone has their own approach. Alberta's the first recently to step into formalizing this legislation through the Compassionate Intervention Act. So they're the first ones saying we are taking, the next steps for this involuntary treatment approach. So that's important to think about. The language or how we're naming it is a little bit different. And I think that does, reflect the intention for it to be compassionate or more compassionate than what we've seen in the past prior to, those more traditional ways that I just spoke about. But at the core of the model, we are still potentially or kind of overtly removing people's autonomy and mandating treatment. So making it a requirement for people to go in. The eligibility for this program are people who are at a high risk. Things that define them as high risk are things like repeated overdoses, a lot of ER usage, potential cognitive impairment. So that's where you look at capacity, or unable to care for themselves in a consistent way. The challenge there is, what does this actually mean? Where do we draw the line? And who gets to decide, the threshold of each of those criteria? And right now in this new legislation, the people who can decide are, family members, potentially police officers, and social workers or care providers that are working with the individual. So, again, you hope that it is compassion. You hope it is rooted in, getting the person support. But we know already in how our system works that there's a lot of risk there and can be a lot of disconnection between, that intention drifting away to something very, very different. So that's, I think, where a lot of the concern comes. And that's where those ethics and complexity really steer, or I think heighten that conversation. And then the risks of it are, Jay mentioned a little bit, when we're mandating people to go into treatment, what if they don't want to go? Like, they're not going to, benefit from the program necessarily. They could also, I think Jay and I have seen many people come to treatment who are not overly excited or wanting to go to treatment. And then, you meet them again 2 weeks later, you see them 2 weeks later, and it's the best thing that ever happened to them. So yeah, just because there's, a lack of engagement doesn't mean that there isn't success, but there is that risk. A big conversation that means a lot to me personally is the fact that, what about the people who do want to go to treatment? There's no beds available. The wait lists are very, very long. So we're prioritizing. It can feel a bit unequitable in terms of, vulnerable populations and people, again, who just may not have access or fit that criteria or have even the supports, right, guys? Like, not everyone has a family caring for them, and not everyone has access to different care teams. And yeah, just, I think from a system perspective, which I know we're going to talk more about today, it's, again, just like we need to be expanding multiple parts of the substance care health system, not just treatment. That's a great option, but it's not always the best. There's outpatient programs, as Jay knows, and there's lots of other resources that are available. So I would have liked to see it a bit more, I guess, multidimensional, as opposed to just one option for people to use.
I think one of the things that that I really, whenever I have these discussions with anybody, one of the things that really drives my push, like, I don't know if it's my resistance or even my buy-in. I don't know. Like I said earlier, it seems to, I guess what you'd classify me as a wishy-washy debater, because I really don't know which side I stand on half the time. But I guess one of the what I'm curious about is, do you believe that if addiction is one of these conditions that qualifies, and then does the person who's actively being challenged by that addiction have the cognitive ability to actually make that a decision anyways, right? Like,
yeah.
It's tricky, right? If a family member is really getting like torn apart, and if the family's getting torn apart and they're at their wits' ends, they don't know what else to do. And it's become that, maybe the person isn't directly threatening to harm someone or directly threatening to harm themselves, but they're watching the person, their loved one, harm themselves, through substance use. Where does that line come? Where do we draw that line? Like, where, and is there a potential for misuse if we start saying, okay, yes, any family member that's, is there, like when you mentioned criteria earlier, it's going to be, I can't imagine the criteria being very specific on a case by case. It's going to be probably broader and generalized. Like, exactly. I mean, how do we determine, right? It's scary.
Yeah. It is scary. And that's exactly, you hit it right on the head, Jay. It is very ambiguous. And, I think it highlights that we don't have an aligned kind of universally shared approach to substance use around conversations like, again, capacity, harm, safety, autonomy. All of these things are really at almost like an intersection of how we support the individual and support the family. And at the end of this, whether it's talking about someone going into treatment or getting formed by a hospital or going in for involuntary, for an involuntary treatment intervention, at the end of the day, who's deciding those things, and when does it reach the point? When are we all in agreement that it's reached a point that we are overstepping someone's autonomy to make their own decisions? And then another thing that I think about is just like recovery is so important. And I've learned from the best of the best, including, you, Jay, on the call and so many others, that people, it's their recovery. And if we're not taking this, this empowered approach from the start, I worry what the long-term recovery is going to look like if from the beginning we're saying, well, sorry, you don't have the capacity to have autonomy over your care right now, because people will get better and they will, start to make a change. And then I just can't imagine what that would look like in a mandatory program, if that makes sense.
Well, it does, but I guess is autonomy always the highest value, or or does preserving life come first, right? I mean, it's tricky. It's tricky.
Yeah.
I don't know. Go ahead.
Okay. I was just going to say, like the criteria for determining who gets the involuntary treatment, right? I mean, that's kind of what it comes down to. And if somebody's clearly harming themselves or others, they're as you mentioned, Alex, one of the things they look at is continued overdoses, and there's lots of I've got a friend, for example, who I met in the rooms of recovery, and he was from the Netherlands, and he was a heroin addict. He was sent away to this treatment place where it was in the middle of nowhere. I mean, you would have to walk something like 150 miles through the bush to get back to anywhere, any type of civilization. So basically, he was locked in. It was a forced situation. He ended up becoming clean. It's now been like over 25 years for my friend Fred, who's now clean. But that's where something where he was. I mean, a lot of people are in psychosis when they're in their addiction. They don't really understand what's good for them when they think there's little people staring out their window, looking in their window at them, and there's a lot of stuff going on, and you're not necessarily in the best place to know how to take care of yourself. And obviously, I think this is one of the driving reasons why we're having this debate in the first place. Why we want to have this. It's part of us. I mean, if we don't all agree with it, certainly I think we can all agree that would be a great thing if all these people were to get treatment. They're not in a place to voluntarily say, I'm ready for treatment. I mean, first of all, when I went to treatment, I didn't know what I was getting into. I had no idea. And so, what transpired as a result of treatment has been phenomenal and amazing. And I just wish everybody could have this, as somebody who's gone through it. But not everybody realizes that. I mean, very few of us would realize what we're getting into when we start treatment. So, to me, there's an awful lot of pros as to why we'd want to do something like this. And if the worst case scenario is, I'm sorry, but my rights as an addict who's hurting myself and others are infringed upon, I look at it like, too bad. Because I'm hurting myself, I'm hurting others, I'm costing I'm using up resources that can be used for people, as Jay mentioned, or as you mentioned, that they're waiting for beds that want the treatment. Like I'm using up resources for healthcare and everything else, and I'm using up a lot of the money for this, and And it's a problem. And so, I maybe just need to try something different because what I've been doing is not working. And, and as you mentioned, there's a lot of people who go into treatment kicking and screaming. And 2 weeks later, as you mentioned, they're saying, wow, this is amazing. Wish I'd done this sooner. Probably most of us would be on that side of things. So,
Joe.
So what do you think about the
everyone? I'm just wondering, is it like, I know they're adults and adults are responsible for their own decisions, but is it also like, you take your kids to school, they start in kindergarten and they don't want to go, right? And they're crying and I don't want to go. And then, like you said, 2 weeks later, they love school. Is that a similar thing, you think, or am I thinking the wrong way?
Well, that sounds like fear-based, right? That's an uncertainty. Whereas, and it's all fear-based. I mean, I guess there's a similarity in the sense that there's fear. I think what I'm interested about is on that note, Vic, like the research shows that like most individuals with severe addiction experiences, it impairs their decision making, right? It's part of the cognitive piece that's impaired. Which means the part of the brain responsible for judgment and risk is not functioning normally. So if the ability to choose is compromised, is it truly a choice to refuse treatment anyways, whether it's fear-based or not, right? Like there's no way to determine that. So I guess there is some similarities. I mean, I would suggest that there's similarities, but based on different cognitive response.
Mm-hmm.
What do you think?
So I want to mention a couple of things to keep in mind because this is exactly why this conversation is so challenging. But there's a few things that we don't know the answers to yet, which I think are really important. One is this is all theoretical in my view as at this point. We don't know what this is truly going to look like practically. So yes, we hope that this is all going to be well-intended, that it's a compassionate, effort and approach to get people into care. But like being real, we know that this a lot of the time is not the case. It's not done compassionately. It's done in a very stigmatizing way. It's done in a very authoritative way because police and, power structures come in. I think there's a real risk here that we are harming certain individuals as well when it comes to trauma, intergenerational trauma, and things that we've done in the past that we just have not done well when it's this kind of top-down approach from a system level. So that's one thing. The other thing too is where are the partners that are creating these programs? Yes, we would love for everyone to be sent to Hope Valley. That would be a wonderful treatment. We know that once we get them in, they're going to be cared for, they're supported, they're going to be loved, they're going to be getting a treatment that they deserve to have, that's dignified and that is rooted in recovery and all the principles that we want to see. We don't know the answer of that yet. Where's the leadership treatment centers? Are they coming forward to say, these are approaches, this is how we're, collaborating with different community providers? That's a big question mark as well, which I think for me to make a decision one way or the other, which would have to be a change from it being something I would support. I would really appreciate learning more about those, organizations and stakeholders involved. And then the last piece is, again, as we're talking, I keep thinking about just across the board, there's no unilateral approach to how we're supporting people who are struggling with substance use or struggling with their substance use health. And that alone is a problem because my worry is we're going to spend so much time fighting about this and arguing about this and it being a tension point again from a policy perspective and even a political perspective that we're not spending the time where it deserves, which is like the implementation, the planning, the care, most importantly for the individual, and doing it in a way that can balance both sides of this discussion. Because I get, Joe, what you're saying, absolutely, this is a way for us to maybe really get, some shifts and people help and, we'll be able to increase access and all of those great things. imagine if it's done though in a way that hurts people worse, and then everyone wants to leave, and they haven't used for a couple of days. They come out, and we all know the risk of, overdose after a period of abstinence, and people come back, and we're looking at the same issue, except further distrust with the system. And I don't think the system right now can afford further distrust from their potential service users, like those who are struggling with their substance use health. I think right now we have to be taking every step we can to develop trust and prove that the system is there to support each individual, regardless of what that is. I don't think matters as much as how we do it as a system.
No, that's you nailed it, right? I mean, we know about that period of abstinence and then the reduced tolerance and the risks associated with that. After that's actually one of my arguments, right? When I flip flop here, like, and then you mentioned trust. I mean, it's interesting you mentioned trust. I mean, therapeutic relationships are built on trust, safety, collaborative elements. They can be harder to establish when choice is removed. So I guess really, I mean, can healing really truly happen without trust? I mean, there's a lot of amazing humans out there that can build that, but I mean, if you're going in, if it's involuntary and you're so resistant and so rigid, maybe you don't hear the magic, you don't have that aha moment that Joe was speaking of. And many do. I've witnessed it with others. If I'm being honest, I think I did. I don't know if I ever really went to treatment because I wanted to recover. I think I went there to get the heat off. I wanted to get my kids back. I wanted to.
I think in either of those situations, not to assume for either of you in terms of that shift, but at the end of it, there were trusting relationships. I mean, I've worked with so many teams and so many people who are there on a day-to-day basis at a treatment center. I have never come across one person who doesn't want to develop trust with someone who's engaging in their recovery or starting their recovery. Not one. Because the system is designed on trust and, someone wanting to come in and it being voluntary and for that choice to always exist. So it is an interesting thing to think about, that if that trust wasn't there, would you guys have made the shift while in the program?
I agree with you. Trust was inevitably going to happen. And I've seen, I've worked at a few treatment centers, been in treatment center, and what I experienced was people that I connected with, counselors, might have been different than the ones that Jay connected with, but there's always somebody there who we connect with, and somebody, and maybe multiples. But what I think is, if there was a way, is there a way to measure success in terms of recovery? Like, can we say that, for example, 12-step recovery has got seems to be the best method of recovery, the most successful method of recovery, and the stats show this, and long-term recovery, people in long-term recovery, generally speaking, are members of 12-step recovery, and we can show, is there data we can show that signifies that this is the case? And if that being the case, can we not use that as one of the criteria for say, an involuntary recovery treatment program?
I think that's a fantastic question. Success and data and measurements. I mean, this is stuff that we have to include. I do think that there's a lot of data that, this conversation could potentially pull on, certainly from the 12-step community, Joe. Right now, how it feels, and I may either need to learn more about it or just not have all the information yet, is it feels like we're measuring success for involuntary treatment as the entry into a program that medically stabilizes you, not a level of engagement around treatment and recovery. That's the feeling that I get for these programs. They're in very, again, institutionalized type of settings. It's very health focused, which it means, we're going to see a priority over like a diagnostic medical approach rather than a holistic whole person approach. Again, might be making assumptions here, but I do know the system pretty well. And I have a feeling that those successes are going to, again, be defined by someone being put into treatment. They stay in treatment. They could be totally over medicated. They're stable in terms of no longer using the ERs and having, the overdoses, and their family is feeling a bit better, and, things feel more stable. But that's not recovery. That's not long-term success that I'm used to defining for recovery. So I do think the point you're bringing up is excellent, and maybe something for us and the listeners to think more on or learn more about in terms of what that's going to look like for them.
Put the plug in the jug approach, right? It doesn't,
Exactly. Yeah, exactly.
Alex, or even Jay or Joe might have the answer. I've heard restaurants like Tim Hortons and McDonald's are putting in blue lights in the washrooms so that those who are going to do drugs, they can't find their veins, for example. And I'm not in the recovery world. I don't know much about, this is all brand new to me and very informative. But how big of a problem is it in this country? And why isn't it like under the rug type of thing? That's my perception, that it's kind of hidden. Is it a huge problem?
I don't mind jumping in. I think it's a huge problem. I work and sit on boards with many very reputable and, impactful Toronto organizations that support with, the harm reduction approach, which I know is, again, another controversial discussion for some. But the reality is, look at the topics we're talking about right now, guys. We're fighting over whether or not we save people's lives or we don't save people's lives, or we offer support when there's no other supports for, here's a perfect example in my mind. If we look at the severity of the opiate crisis from a safe injection perspective, we are basically saying you cannot get that support. You also cannot get access to support. And unless you're someone who qualifies or others deem as someone who qualifies for these supports, you also cannot have a mandatory involuntary treatment path into things. So people are left with nowhere else to go, nowhere else to go. And the result is that, and we're seeing this already, is it's just worsening the problem significantly. So Victor,
I just feel, Alex, though, like when you say, are we saving people's lives or are we not saving people's lives? I feel like that's not really the question. I feel like the question is involuntary treatment a solution to saving people's lives? Because I don't know, forced treatment. Okay. If we look at the disease model of addiction, right? And we can all agree that it's an illness. 2007, when it was deemed an illness by the American psychiatric community, there's no more argument. There's no choice theory anymore. And so we can agree it's an illness. We agree if it's progressive. The discussion last week with Glenn really highlighted the reality of this. And, so if it's an illness and we're not responsible for our addiction, but we are responsible for recovery. So I go to the doctor today, he tells me, Jay, you got diabetes, you got to check your insulin levels, you got to take, do X, Y, Z in order to manage this illness so you can live, right? But now we're saying, and a big component of the recovery aspect is taking some ownership and responsibility for your action to get well, right? To take those necessary steps to do what you have to do to manage this illness. So if we're talking about forced treatment as keeping someone alive, isn't there, couldn't that sometimes shift responsibility away from the individual and onto the system? And then are we helping people take ownership, or are we actually taking it away from them?
Yeah. Another great question. It really just comes down to the how for me. How are we doing this? Because there are going to be tons of people, to both your points, that this could potentially help. Families, individuals themselves. We can't really ever know the answer to that. But, how we do it as a system is going to make all the difference. We don't have the best track record. We don't have the greatest track record when it comes to collaboration.
So
like I'm thinking about some of the initiatives that I've worked on over the years, and like it is hand holding, walking together. We are both two different teams, two different whatever, but we need to approach this together. That's not how the system works, guys. Like it would be fantastic if that was at the root of our system. And I think these conversations would be a lot easier to have, and the implementation would be a lot quicker if that was our fundamental approach. But the reality is it's not. And so yes or no, pro or against, wherever you stand, it's going to be disconnected. It's going to be not well prepared. It's not going to include the families and the individuals and all the stakeholders the way that we would all prefer for them to be included. And we're seeing that already with the rollout of it. Like I define the criteria. It's very ambiguous criteria. Like how many ER visits are we talking about? Capacity, that's like a formal assessment that would need to be done in terms of capacity. Who's doing that assessment? Families are doing that assessments. They have enough on their plate. They're not trained professionals to do a cognitive assessment on their loved one. They have anecdotal information on that, but they're not able to do a evidence-based medical assessment on the individual. And same with our police services or our enforcement. Like that's not their job. That's not their scope of work either. So all these questions come to my mind: is are we setting everyone up for success, saving lives, getting into treatment, however you want to define that? To Joe's point, are we setting up everyone for success with this current structure we have in place? And if not, who is leading the conversation to make those changes?
Well, in the big book of Alcoholics Anonymous, the recovery book, there's a doctor's opinion. And when the doctor's opinion was introduced in 1937, when they started writing the book, it was very controversial because the doctor's opinion was based on his research of, being at Towns Hospital in New York City. We're working with thousands of alcoholics, and his findings were that the only program that he had ever discovered that worked was a program that dealt with the mind and the body, which was the Alcoholics Anonymous, right? 12-step recovery. And the reason that things changed is because they developed a spiritual solution to a spiritual malady. And it worked, and it's worked for like millions of people have died sober. Millions of people are sober today all around the world. And it seems to me that the people who would have the input in terms of developing this program, this format, would be people who have worked with other alcoholics and addicts, people who have recovered from the disease, worked with other alcoholics, seen them recover, and seen where the success is. And Hope Valley, Addiction Rehab Toronto, and Alpha House, and all these people, all these programs recover that have success, and they see what the success is all about. And those people who have gone through it and come out the other side, it would seem to me that would be the place to be going to for developing criteria, developing an across the board program. What works? Okay, who's sober? Who's sober? Okay, Joe, how long are you sober? Well, I've been sober 34 years. Do I qualify? Does my opinion matter? Jay, and so forth and so on. And it seems to me that there is an opportunity to rather than somebody who's maybe studied alcoholism in university, right, and learned everything I can learn about university, and PhD, everything else in alcoholism. I know this. I know this how this works. I really studied all of it. Or the alcoholic who's been through it, and it's like who understands the disease better is my point. And so if we have, and I think there are certain I think if we were to do some research and come up with a sort of format that is maybe done as a team of doctors working with a team of recovered alcoholics and addicts and talking about what has been working for them and coming up with some sort of a program that makes a lot of sense. If we were able to do something like that, and I understand that this is a complicated thing to put out there, but to me, it doesn't seem like it should be that complicated. Okay. I mean, can we not go to, if we're going to do this in Ontario, say, for example, can we not go to a bunch of recovered alcoholics in Toronto and Ottawa and Windsor and Kenora and across the province and say, what do we find that works, guys? What are we doing that works here? And then, have a team of physicians who are experts in the field of, alcoholism and addiction and come up with a team, if you will, and that. But it has to be people that have been in the trenches, people that know how it works, and people like who run treatment centers, because Dr. Silkworth, who was with the doctor's opinion, had worked with thousands and thousands and thousands of alcoholics, and he watched them all die. Your choice is wet brain, insanity from wet brain, or death. Because that's what's happened to every single alcoholic and addict who's gone through my hospital for 15 years. And now we got this group of individuals who've come up with this new program of recovery. And hundreds of these guys are leaving my hospitals clean and sober and not coming back again. So something's going on here. Why don't we use that experience? Why don't we use that valuable asset and create a program of recovery that we could, I believe, safely use, that maybe a real good portion of sober people I know would be happy with as a way of, if you're going to introduce involuntary treatment, then this is a program that I think can really work. This is a program that I think that can really, check all the boxes, right? Check off all the boxes. Because, who knows?
Can I jump in, Joe? I just want to jump in just for a brief.
I really love what Joe said. Okay, I took notes, so I'm not going to lose my mind. But after you, Jay.
I just want to play. I want to play both sides of that just for a moment. And I mean, because when Noah's mother lost her sight, she lost her vision. Right, she went blind. She had cornea transplants in Sunnybrook, and I remember going to visit her, and I wasn't thinking one day, and I had a Mother's Day card, and I handed it to her, and it hit me that day. I'm like, she can't see, right? She can't see, and it was, I really care a lot for Noah's mom. She's family. We love her, and I really wanted to. I can only imagine to go from sight to blind in an instant would be terrifying. I just can't imagine what that would feel like. The more I thought about it at the time, I was like, that's got to be one of the single most terrifying things. And then I really wanted to understand what it would be like to go through life without sight. And, I wanted to imagine what that fear would be like for her. And you see what I would do, Joe, is I would close my eyes, right? I would close my eyes and I would try to imagine what it would be like. But you see, no matter how much I care and no matter how compassionate I am, no matter how much I love, no matter how much I really, truly deep down inside want to understand and really, really just put myself into that empathetic reality of where she's at, I know that I just truly can't quite get there, because at any moment when I want, I can open my eyes, right? And so that's the strength in having the people with the lived experience be a part of this solution that you're speaking of. The other piece of it, though, is the bias that comes, from guys like me that have found, I've tried 7, 8, 9, 10 different things. And I found that the solution laid also in my personal story was in that same book. And am I at risk of getting stuck on that this is the only way, the only solution? And therefore, I'm now closing the door on other opportunities and other avenues that may be more effective for someone with some other co-occurring disorders, some different mental health challenges where they use alcohol and drugs to cope or self-medicate, or let's take it to the extreme, blow up their entire lives, right? Like that bias piece is interesting. I don't remember if I've shared on it before, but when I was a little boy, I remember my mother saying to me, you have to eat your broccoli or you're not going to hockey. And I remember saying, I'm not eating my broccoli. She said, well, why aren't you eating your broccoli? I said, I don't like broccoli, Mom. And she said, how do you know? You never even tried it. And my response at that time, even as a child, was, I just know. How do I know? I've never even experienced it, but I've created that bias. I told myself something and I believed it even at that young age. And therefore, it's a really fine line. Interesting enough, and before I give it over back to Alex, when Alex and I first met, these were long before involuntary treatment was a discussion. We were speaking on, I think from the very first time we ever met, about the collaborative approaches that we need to take in order to have long-term sustainable solutions.
100%. Yeah. Yeah. It makes such a difference. Okay. So I took notes because I want to make sure that I adjust everything. And one is, Joe, when you were speaking, I don't know if you noticed, but I just had a growing smile on my face because just your point around people, I'm imagining you and like Jay and Jordan going out and doing this and helping people. And I'm like, oh, we're good. Everything will be good. We'll make sure that we're getting people in the way they need to be supported, the conversations that need to be had. I mean, I really want to commend you for valuing that lived experience piece and for incorporating not only people with that experience in the process, but also in the development of this. And again, something for us to look at, and I can look into it for sure, is how much have people with lived experience shaped this policy? And I'm not overly confident there have been a lot of lived experience perspectives in this policy and legislation change. So that's the first thing. I really want to commend you on that. It's an approach that I couldn't more firmly stand behind in terms of people with lived experience being at the forefront and leading us through these changes and these transitions. The next thing is you mentioned spirit, and that's the piece that I think is really important to remember too, because at the end of the day, the reality is, guys, the people we're going to be supporting through involuntary treatment are neither of you. This is not who we're looking for. And this is not going to be the people that we are going to be supporting. They're going to be my beloved friends and people that changed my life working in the shelter system, whose spirits are broken because we have a system and we know what kills spirits. We know disconnection, loss of meaning, a learned helplessness, shame, self-doubt, feeling unseen, feeling unheard, chronic, stress without recovery or option for care. Like all of those things are exactly what people who live in the system day to day experience every moment. They're told, go here for help. They can't get help. They're told, go here to sleep. The doors are shut. They're told, come into this program and we'll help you stabilize. You can only stabilize this far because you don't have access to any of these next steps. So spirits are already broken, in my opinion. And then we're going to take this approach that isn't designed by those with lived experience, that doesn't include those that have lived experience. And I think about it like this, guys. What is really happening is the police, family, and social workers are becoming interventionists. We all know that is like a trained, skilled approach, right, Jay? Like not everyone can be an interventionist. It is a very delicate, nuanced conversation. We're leaving it in the hands that are either they shouldn't be doing that. Family member has a lot to do already and have a lot to go through and are struggling to just get through the day and manage all the worry and everything that's coming up for them. Then we have enforcement who's trained to enforce, not to intervene. And then we have potential community workers, social workers who may have a bit more, training in this, but are not in the scope of something like an intervention. Just those few things, guys, is not setting us up for that well-intended, get people in, we can save lives, and this is going to make a positive impact on the crisis that we're seeing.
Right.
So those are my
Yeah. Okay. That's good. Thanks, Alex. Okay. So in 12-step recovery, we have groups. We form groups that do volunteer work. PIC, CPC is cooperation with the professional community. PIC is we go and work in the community. And if we were to form, for example, 12-step recovery, NA, AACA, whatever, get together and form this new group, call it for lack of IRC, Interventionary Recovery Committee, right?
Love it.
And so we formed an interventionary recovery committee, and we are able to be, as this new committee that we form, say in Ontario, as for starters, we start this committee and we start having meetings, and we make a proposition that we're looking for people who have got long-term recovery. By long-term recovery, I think people basically have been through the steps and helped other alcoholics and addicts and know what that's like. So we start this committee, and then we bring this committee to a point where a police officer engages with somebody who, in his opinion, this person needs involuntary treatment. And they have a call, 24-hour line. They call the IRC office, and the IRC officer, because everybody takes the phone home with them, makes a call to somebody. Either they're available, or they make a call to somebody who's part of that committee, and they make themselves available. And this person goes out, and maybe a couple of people go out, and they meet with the officer, and the officer introduces them to the person that they want to have this intervention with. And we can do it like that. I mean, that would be, to me, that would be a committee that would be formed through the 12-step recovery realm, and that would be something that would be a way for it perhaps to be helpful, or maybe just to work. Yeah. Right.
I mean, Joe, you're a system changer, in my opinion. I mean, what you're recognizing and offering is these are the options that we need to be creating. I mean, even in the work that I do right now, which is quite a bit different than my experience in the treatment side of things, is it's these really unbiased, third-party assessments that we can offer as a solution potentially too, right? Like ever since I was thinking about this topic a couple of weeks ago with my team and sharing, this is coming down the pipe and this change is going to happen eventually, but it's so tense and it's so controversial. And I think if we can lift that decision making from those stakeholders to confirm or not confirm capacity, for example, and or the treatment plan for an individual, like really neutralize it, Joe, if you will. So instead of it being like enforcement, police making this decision, which there's always going to be a group that's going to question that because of history of how these things have been developed, right? And like family will be questioned too, or maybe they won't even want to make the decision. Right. So we have a real risk around the consistency of it, the ethics around it, the practicality of it. So I'm like, this would be great to offer assessments to say, everyone doesn't need to fight about it. We're going to be a neutralizing party here to say yes or no, this person has capacity, or they don't have capacity. If they do have capacity, they need to be given the autonomy to go into treatment that's available in a voluntary way. If there's limited capacity, let's get them into this, proceed with the intervention, and we can get them the support that they need. Right. So to your point too, if we stepped in around it makes me curious if we stepped in from an assessment perspective, and then we had the IRC backing us up in terms of knowing that this would be a consistent approach each time too. I mean, this is where I think there could actually be such a positive impact for something like this. And I think we need to pull our contacts together, Joe, and have these conversations with decision makers, because this is truly the stuff that I think needs to be, factored in.
And this is, to me, it's 12-step work, and to me, it's
Right.
it's the type of work that a lot of people that I know would be happy to do it for fun and for free. You know what I'm saying?
I know.
It's just a way for me to give back and be of service. And we could just be recovery warriors, getting in the trenches, doing these interventions. It would be good for my spirit as a sober member of a recovery, 12-step recovery. It would be good for my spirit. It would be good for my soul, and it would be helpful, to whoever is out there.
I think it's so. It's so wonderful that would be something that would be available, and for funders and our politicians and, people making decision around policy, free service is always a great option. It's going to be well received. And
Easy
you've mentioned
sell.
you've mentioned trenches a few times, and I know at the front end of the call, I just feel like I need to share this in the conversation. But at the front of the end of the call, I was talking about COVID-19 and the hotel shelters that, I had supported with opening and creating. And when I left the organization, I got a dog tag from one of my kind of bosses, colleagues at the time. And it said, it was something revolutionary, but in the card, it was like, no one else I'd rather be in the trenches with. And it was so meaningful because if there's one thing that maybe I can bring insight on in my career and in these conversations is when you work in the shelter system and when you work in the system itself and you see how truly broken it is and you see how, so many people are impacted. You see how many people we easily write off based on how they look, smell, walk down the street, whatever they're doing. Like we write off saying, oh yeah, they're a crazy person or they don't have any capacity or blah, blah. Those are the very people that want help. Those are the very people that come to me and say, Alex, there's nothing more that I want than to go to treatment and to get out of this cycle and to get out of the system. But there's nowhere for them to go. And 6-month wait lists when you're trying to survive and find a place to sleep every night and then you have a different care team. You don't even have ID. I was going to swear, but how the F does someone follow someone in that vulnerable situation for 6 months before they get into treatment? So the most heartbreaking thing for me is that we have people who are vulnerable, who are at this intersection of, the system not working and options not being available to them. And they want help. They want to get recovery. They want to meet both of you. They want to engage in recovery groups. And there's no one there to help with that. So isn't that the first conversation we should be having right now? Like that to me feels like we need to be lifting those people up and creating a system that supports them, not writes them off, and get them the help they need. And then second phase is, okay, for those that, again, either don't have the capacity, are not willing, have other barriers, we can design this potentially collaborative approach to also get them help as well.
I think the one spot that we just haven't touched on, and we covered a lot, and it's fabulous, and I love everybody's insight. And yeah, Joe, you're a trailblazer. You just don't even know it yet. It's that.
Joe.
Yeah, I know, right? But it's that internal motivator. Like, an apology without change behavior is textbook manipulation, right? And most people who go through the world of addiction have mastered the art of manipulation, whether they know it or not. Usually the first person they manipulate is themselves. And, and so I feel like a lot of people could walk into treatment, and I'm talking now about the individuals that are going through the process involuntarily. And they would be, they very easily could adapt and say the right things, do the right things, and skate on through and call it a day. But if we're in the results business, and if we're in if we're having a discussion about like truly making a difference and really helping people and really giving them an opportunity to recreate their lives and heal, well, it's that, where do we, and I'm not suggesting I have the answer. I do have a thought, but I'm not suggesting I have the answer, but it's like, how do we create that internal motivator to get someone to want to actually get better so that they take the necessary, honest action to get better, like join Joe's movement or to even engage in therapy or whatever it is. And I was thinking, I don't know about, if it's right or wrong, but I think Hope Valley may be one of the first centers to do this, but I'm sure many will follow if it's successful. But we're building what we think is Ontario's first spa in a treatment center. And the reason behind this stems from, I don't know about you guys, but I get busy. I get busy in life, and a sock falls out of the laundry hamper, and some toast crumbs are left on the counter, and there's some mails left on the, and all of a sudden my house gets a little cluttery, and and as that happens, I tend to add to the clutter. I tend to add to the mess. I'm less motivated to clean it. I go through this, and then maybe a week goes by, and I'm like, holy crap, look at my house. And then I spend 5, 6, 7 hours completely overhauling my living room and kitchen and house, making it spotless. And I'm sitting on the couch, watching the Blue Jay game, and I see a tiny little fluff halfway across the room on the carpet. And what do? I get up and go and pick it up. Right. But I wouldn't have noticed that 5 hours ago. And so it's like, what motivated me to want to actually pick up that fluff? Right. And I was thinking, the psychological component is that maybe if we're given an opportunity to care about ourselves, even for a brief second, even if I like myself for a brief second, even if I, feel good about myself for a brief second, maybe that's the piece. Maybe that's the piece that's going to allow me to grab onto it and say, I want more of that. I'm going to try harder. I'm going to want this more. And by in relation to what Joe was sharing, I mean, maybe it's just a matter of having that knee-to-knee opportunity with somebody else who's been there, the person who's not trying to close their eyes, the person who truly gets it. And maybe that's the motivator. Maybe that's the piece that says, I want what he has. I want to feel free. I want that light in his eyes. I want that sense of, I don't know, joy that he seems to have. Why is he smiling and laughing if he's alcoholic, right? I've never understood that myself. I do today, but I didn't for a long time. So I think there's a lot. I don't mean to rehatch the systemic component, but like that's kind of where I think is the most important piece, is that self-internalized motivation,
Yeah. Yeah, we brought up a lot of really good points. It's this conversation has certainly exceeded my expectations in terms of where it's gone. So I want to thank you both for, keeping it just open and respectful, because it is a really hard conversation to have, and a lot of people are struggling in having it right now. Yeah. And for me, what's really coming out as a reflection is just the trusting the system, how important trust is in this whole process. And whatever comes, in terms of policy and legislation, we need to make sure that there's trust at the center of it, or we're building trust in the process. That's what I've really realized from this conversation. So I want to thank you both on that, because I didn't quite look at it that deeply prior.
Well, thank you.
Yeah, thank you. It's been awesome, Alex. But I just want to say too, to Jay's point about, the internal motivation, and it's like, in the beginning, I had no idea what I was getting into. Okay. And I had no idea. And we had Glenn on last week, and he talked about, it wasn't the first or second treatment center, but somehow he got in the third. And for Jay, I think was your fifth, but whatever it is, it's when you have that, it's kind of like, as an interventionist, if we do this with no expectations, and we say, you know what, here it is, here's the message, here's the message I'm bringing to you. Here's what happened to me. Here's where I'm at today. Here's, the opportunity you have. And, it's up to you to take it or leave it, or I guess maybe in this case, it's up to you to see what's good in this and see how this can be valuable or not. But I think you need to give it a try. And if you give it a try, yeah, go ahead.
We have to remember that one of the criteria is not having capacity. Like, one of the criteria for this program is not having the capacity to know the answer to that. So it's conversations that someone may say, or we can't engage in theory with that individual because there's a limited cognitive functioning capacity for the person.
Right.
Do you know what I'm saying, Joe? So it's like the ability to say, I really get what you're saying. You're right. Okay, let me give it a shot. I'm seeing that this is taking an impact.
Not even having that expectation, though. I'm just saying, not even having that expectation. Just an opportunity to sort of carry the message. It's like, listen, I've worked with a lot of guys who've some guys who get it right away. Boom, away they go. Some guys who need it to come again and again and again and again and again and again. But the thing is every time they come, it's like, hey, Fred, good to see you. So glad you're here. And it's like, it's not having a judgment. It's not having an expectation. It's just like, this IRC committee. I mean, I would, if I were heading it, I would say what we're going to do here is we're just going to carry the message and we're just going to talk to these people. And what we have no expectations about what happens as a result of this, but it's an opportunity for us to be of service and maybe be helpful in the process. And that's all it is. And so, if I don't have any expectations, then I'm not going to have any resentments and I'm not going to have any sense of failure here, because just the opportunity to do this is a success. Because it's going to keep me sober another day, and that's the whole point of it. And it's, if there's a positive result that comes out of it, fantastic.
You are heading up the IRC, by the way. We're going to do a vote. We're doing a vote right now, Alex. So, all in favor of Joe heading up the IRC?
Yeah,
Aye.
the system needs you so much.
You voted in.
Yeah.
Thanks, Joe. Thank you so much, Alex.
Yeah. Thank you, Alex. Appreciate it. Before we go, I just want to give a shout out to our great sponsors, Addiction Rehab Toronto, saving lives and reunited families. Hope Valley Healing Center. Healing begins with hope. Alpha House, where recovery is possible and people rebuild their lives. And Matt Apparel, make a difference. Corporate Impact Wear, the official apparel provider of the show. Wear the message. Guests on the show receive a Recovery Comes Alive with Joe and Jay golf shirt. So Alex will get your address and get that golf shirt out for you.
Wonderful.
Mark will take care of you. So
can't wait.
Thank you. Yeah.
Thanks.
So once again, thank you, Alex. Appreciate this time. And thank you, Jay. And good to see you. And we'll see you all next time.
Addiction Rehab Toronto, Toronto's #1 alcohol and drug treatment centre, saving lives, reuniting families. The only treatment centre in the province to offer medical detox, treatment, sober living and lifetime aftercare, all in one place. Our unique and specialised programmes are designed to equip our clients with the tools to successfully lead a life of dignity, respect and purpose. Let us help save your life or your loved one's life. Call today for more information or to facilitate an intervention 1-855-787-2424 or visit addictionrehabtoronto.ca.
Every moment I step on the grounds of Hope Valley Healing Center, there's this immense sense of beautiful energy, and it just hits you when you walk on these grounds, and it's something that you almost have to experience here to really know what our clients and our staff and myself are speaking about.
We believe that healing begins with hope, and here at Hope Valley, hope is truly everywhere. Healing doesn't come easy, but it comes with a choice. You get to make that choice today. You'll regain that power of choice today. You'll find healing here. You'll find hope here. And if you believe it and you're willing, well, let me show you how that happens. Let me show you how we can make this happen together.
Since 1972, Alpha House Recovery Community has been a cornerstone of hope in Toronto. Serving self-identified men 18 and over, our 4-month residential program bridges treatment and long-term recovery. with 24/7 support, counseling, life skills training, and real-world reintegration through work and education. We also offer safe, stable transitional housing to help graduates build independence. With a 71.4% success rate 2 years post-treatment, Alpha House empowers lasting recovery. Alpha House, where community builds a stronger future.
At Mad Apparel, founded by Mark and Dale, we believe in a life of impact. Make a difference isn't just our mantra. It's a call to elevate every part of your life. Your health, your goals, your family, your community. Rooted in service, powered by resilience, we champion those who lead by action. Mad Apparel. Empower your journey, impact the world, make a difference.